Here I'm going to talk about an infectious disease, endocarditis, which bugs are common contributors, common causes of endocarditis. Then, of course, the drugs of therapy, some empiric therapy. And then also briefly touch on prophylaxis as far as who might be candidates for dental procedures and different things of that nature. So what is endocarditis? Essentially an infection of the heart. Bugs are typically, you think of a heart infection. Well, how does an infection get there? How does bacteria get there? Other than an obvious, injury to the heart or a heart surgery or something like that. How does a person get endocarditis without having an obvious seeding there? Well, most often the situation is bugs are deposited from the bloodstream, usually from other areas of the body. So any sort of wound, surgery, mouth, like I mentioned about dental prophylaxis, and IV drug abusers, endocarditis also is another thing that has to be highly looked at as far as a concern as far as infections go. Likely bugs in an endocarditis situation, think gram-positive, okay? So we're going to be seeding the bloodstream. Bacteria may travel from the skin and outer parts of the body, and that's really going to be your most likely coverage, most frequent cause. So staph, strep, Enterococcus, ignore the spelling there, sorry about that. Enterococcus, gram-positive bacteria is going to be the most common cause. Thinking of less common bacteria, you may see gram-positive, but empiric therapy is typically going to revolve around the focus on gram-positive bugs. So management. Like I said, gram-positives, empiric therapy, we definitely have to think about, staph and strep. And vancomycin, linezolid, daptomycin, those are all good antibiotics that cover gram-positives really well. With that said, I think we do have to pay attention and do have to recognize that MRSA is a big concern, and that's why we utilize the vancomycin, linezolid, and daptomycin to ensure that we're covering for methicillin resistant Staph aureus. Now, as we go on kind of throughout management, and we've identified a potential alternative organism other than maybe a staph or a strep, well, yeah, certainly we need to alter therapy and make sure that we're covering different things. If a patient clinically is getting worse and the antibiotic that we're not using is obviously not working due to worsening clinical response, we're going to have to alter and adapt as well. But as far as empiric initial therapy, we're going to really target those gram-positives and make sure we cover for MRSA. Specific targets, MRSA, vancomycin. If we've got a known methicillin-sensitive Staph aureus, yeah, why would we use a big gun if we don't have to? Let's use something like a penicillin antibiotic in that situation. If a gram-negative is identified, third-generation cephalosporins, aminoglycosides are a couple of good examples that's going to cover those bugs typically really, really well. I talked, specifically about, Pseudomonas and some of the other, highly resistant bugs in kind of a previous lecture. So be sure to kind of refer to that as far as, if third generation cephalosporins might not work in some of those agents, but for most bugs that are sensitive gram-negative coverage, third-generation ceph and aminoglycosides are a couple of good options. Now, prophylaxis considerations. So, dental prophylaxis, dental, surgery maneuvers, it can lead to seeding of bacteria into the bloodstream. So, what patients might be at a little bit higher risk, and should we do prophylaxis for? These are basically patients where that sticking of bacteria, that seeding of bacteria is a little bit more likely. Any type of pre-existing cardiac injury, any type of valve replacement might be a little bit higher risk. Any type of transplant patient might be at a little bit higher risk. And then obviously if they've had a history of endocarditis, we're likely going to be wanting to use antibiotic prophylaxis for some of those procedures. Agents for antibiotic prophylaxis, amoxicillin, clindamycin are really going to be the most common agents. In the event of penicillin allergy, clinda is going to be the drug of choice there. For some reason, it's known that there's a high incidence of MRSA. Clindamycin might have a little bit better coverage there than obviously the amoxicillin as well.